Hi, folks. Thanks for joining us today. My name is Megan Lenz. I'm the Director of Communications here at QRSMA, and I'll be moderating this call today. It's just a little bit before the top of the hour, so we're going to give another minute or two for other folks to join us, but then we'll go ahead and get started right at noon Central Time. All right, everyone, thanks again for joining us. We're going to go ahead and get started. Just a quick note, we asked you to submit some questions when you registered, and many of you did, so thank you so much for that. Depending on what sort of device you're watching this webinar on, probably on the right side of your screen or across the top of your screen, you'll see a little box that says questions. What you can do is during the presentation, just go to that box, type in your questions that come directly to us, and we'll answer questions at the end of this presentation, both from those that were pre-submitted and from those that we received during the webinar. With that, I'm going to go ahead and turn it over to Kenneth Hobby, our president, and he's going to lead us through a presentation. Just one quick note, on many of the slides you'll see there's quite a bit of text and quite a bit of information. In the interest of keeping this moving and getting to as many questions as possible, we're going to keep it high level and focus on some of the newer developments, but we will be posting this presentation and the PDF deck on our website, and so if you want to look at all the slides in more detail, you'll be able to go back and do that afterward.
So this is a regular communication that we've been trying to give to the whole community, and we've been trying to do this about every other month. The last time we did this, though, was actually at the annual conference, and so some of those materials hopefully are available for everybody if you want to kind of look back at historical information and how things have progressed over this year. But what we're going to try and do in this webinar is give an update on where access currently is, what we kind of know with current numbers of patients getting dosed and sites that are up and running. We'll get into then just what the current kind of activity is that all of you in the community and we are focused on in terms of increasing that access. And then a little bit kind of longer term as well, what we see are going to be projects that we need to work on over the next few years as well. So to start off with just a few slides that go over what we kind of see as the current picture of access to Spinraza. And so some of this is from formal information that comes out from the company. It's also information that we're able to collect directly from families and just looking at kind of anecdotes and social media postings as well. So our estimates are, at the current time, there's probably about 2,000 patients in the US who are getting dosed in some way. The majority of those are going to be through the commercial programs, which is obviously commercial coverage, but also the Medicaid areas. That's kind of the whole commercial aspect. There's probably about 250 and then another 200 that are included in that 2,000 who are getting access to the therapy through the expanded access programs, ongoing extended clinical trials, and then also the support programs as well. What we've heard and what we've seen is in that group of patients that are getting dosed, there is a wide range of all types that are getting dosed, and age ranges from very young up to adults and older adults as well. So there's definitely a good range that's included there. There's obviously certain groups that are not getting kind of the numbers that we hope for at this point in time, and that's what we'll get to with some of the information on what we're currently working on in the future as well. But in terms of actual dosing, there is the full range, all types and all ages as well. We are up to about 120 sites, again, just in the US here, and that covers 40 states where there's at least a site that has dosed one patient. So there's about 120 in the US. There's about 230 that includes that 120 where they've either dosed or submitted one of the start forms to get the process going as well. So the next slide summarizes a project that we've been working on, which is to collect the information of these sites that are dosing, that are getting up and running, that are available for people to actually get in contact with. So this is our public list. And there is a difference. We don't have all of the sites that are dosing or all the sites that have even started kind of the process on this list. Some are waiting until they're really ready and up and running before they're going to put their contact information out. But we're up to about 80 sites that are now on this public list, and that's on our website and the contact information there as well. We then have an additional 177 that we're looking at as pending sites. They're sites that we know have an interest that we're working with to try to get them up and running and actually dosing patients. So if you plug those two numbers together, you'll see that we're up to about 250 sites that are either up and running now, getting ready, and that's a really good number, we think, for where we want to eventually end up. If we can get all of those 250, we think maybe 300 is what we're going to need ultimately to be up and running, all dosing, and dosing good numbers of patients as well to meet kind of the demands, the needs that we have to get everybody access that we think is going to want access. So we're still working on a lot of those sites to get them up and running, and there's kind of a lot of advocacy work that goes on there to get them information on SMA, on the therapy, information on just kind of general protocols for SMA as well, so that those sites are ready to dose patients. We said this before, and we're definitely still seeing it, that it's really probably an expectation to have definitely this year, and it might go into next year, that some of these sites are going to specialize in particular ages and types of patients. Some are going to prioritize certain kind of groups over others, and some, when they kind of have backlogs, they're going to have to kind of randomize who they get going first. So that's kind of an expectation to have. We want to improve that over time. One of the things that we want to make sure is that we get enough different sites going, in enough of them in each individual state, so that everybody can get access. You might not be able to get access at one hospital. They might specialize in a particular area, but if we can get enough hospitals going, we'll be able to get the access that we want. So the next slide just summarizes some charts of kind of the progress that we've made over this year. So top left is just about the number of patients that are actually getting dosed now, and this is the commercial side, not the trials or the support programs. And so, we've gone from none at the end of last year to where we think we are now, which is about 1,600 in the US patients getting dosed. The bottom right is about these sites that we got up and running as well. So again, we've kind of gone from nothing at the end of 2016 to where we think we are now, which is 80 sites that are public, ready to be contacted, and dosing patients. We've got about, at 170, 180, where we know they're out there actually dosing, but then they might not be ready to kind of accept a lot of patients calling them yet. And then again, what we're aiming for is to get those numbers all the way up, both the public list, but ones that are actually dosing to the 250 to 300 range. The next slide, we just wanted to actually show this as kind of one of the impacts when a new therapy is approved. This is the tracking that we have of newly diagnosed patients month by month. The bottom blue line is kind of previous years, 2016, and then the red color is what we've seen over the last year, and you can kind of look at December there for the red line was when the approval came through. We just wanted to show this as there's an impact with the therapy, and this is actually good overall because it's about greater education, greater awareness of the disease. And what we've seen is a lot of patients, more than in the past, actually getting diagnosed with SMA. What this also includes, though, is not just newly diagnosed right now, but it is patients that were diagnosed in the past, sometimes quite a while ago, but had never actually come into the community. And this kind of new treatment is now bringing these groups of people back into the community now, and that's why we're seeing these spikes go on of more patients coming into the community. The next slide is just what we're aiming for, kind of a summary of these goals again for the sites, what we're trying to actually eventually get to. So again, we want the 250 total number of sites overall in the US, but we're building this up over time where we're starting hopefully with just one in each state to get going. We then want this balance of making sure that we've got an adult site and a pediatric site in each state. And then some states, because of the greater population, greater numbers, are really going to kind of have to have multiple locations, not just the two, one adult, one pediatric, but multiple sites in those kind of high population states. So some of the things that we're working on are two levels, I think, with these sites to get them up and running. One is certainly kind of just the advocacy and education part to get new sites, which is what we need, aware of SMA. And I think we've done pretty good at that. When you look at the numbers now that we're communicating with and appending, what we're also kind of moving towards, though, is not just awareness of SMA and that there's a treatment now available, but educating them on what the benefits are, what SMA really is, and how to care for SMA patients. So we're kind of in that phase, I think. Well, we're also just starting now launching some programs where we're actually helping with direct resources as well. So not just information, but resources to try to help get sites up and running, but also get sites that are now kind of ready, getting the maximum number of patients going as well. So the next slide summarizes some of this actual funding support that we've just launched, just rolling out right now to try to help what we're looking at here, which is getting greater numbers of access for patients going on in the US. One of them is focused on sites that are already up and running. How can we help with backlogs that might be in place, just kind of general administration, scheduling, and items like that. Another one is to try to help some of the newer sites get trained on SMA. And we're particularly starting off by focusing on physical therapists and occupational therapists who are going to be involved in a lot of the measurements with access, but also just general care for SMA patients as well. And we're trying to bring in new therapists into the SMA field, and we're hoping to bring about 40 of those in. Jill, is there anything you wanted to add on that area?
No, just I think for our site funding to deal with administrative hurdles, we have the deadline by October 6th for sites to apply. And as the slide says, we're hoping to fund 8 sites, and the funding will be given out to the sites before the end of the year, hopefully sometime. We'll notify them at the end of October, and people should have funding in hand to do this in November.
So I think the next one, next slide that we're going to go to, Megan, do you want to? We're going to switch a little bit now and move more to the insurance area. This first slide is just kind of, again, a summary of what our goals have been and kind of the initial situation that we were looking at. And then we'll get a little bit more into detail of kind of the current activities where we're trying to improve the insurance coverage and the reimbursement. And then actually some of the future stuff, which we're just starting to get into now, which is the stage of actually not the first approvals, but renewals and reauthorizations that come through. So as we've kind of gone through the last 7-8 months, we've definitely seen that there are some variable decisions that the insurance providers, the commercial and the Medicaid providers have in this area. There's some variability there. What we've also seen over time is that there's certain kind of areas, criteria, where people are saying they want to see more data, people meaning kind of the insurance providers there. They're looking for more information and really kind of published information in particular to reinforce the benefit and the need of Spinraza in particular groups. So we kind of break that down to make sure that there are already publications out there for a lot of these kind of questions already published, and that's just a matter of making sure that these providers know that that's out there, getting them copies. I think that's important for the community to know as well when you might get an objection or a denial. If there's already publication data out to support from the clinical trials that there's a benefit being shown, it's important to get that information kind of quickly moving through. There's another category then which is more about publications that need to come out. We've got the data that's available. It's actually been studied in clinical trials, but it's in this process of now getting it published in journals. And there's some data that is there that we're working, and I know Biogen as well and the clinicians are all working to get out there with some of the other trials that haven't been published yet, and also some of the data specifically on the, trach as well, trach patients that were in some of these trials. Then the third group is actually areas where there isn't data available, that there isn't data from the trials that was studied, and this is kind of looking at the fusion area, and then also older patients and type 3, type 4 patients in particular, older adults. There isn't data from trials that's available right now, so that's something which isn't about pushing publications out, as opposed to actually collecting more information now, collecting more data that can be used to show to insurance providers. And then finally, the item that we are starting to get into is, this isn't just kind of the initial stage of getting approvals, but what we're going to deal with here, and we'll kind of say why we're going to deal with it, but is ongoing proof that there's going to be the need to show that the therapy is working to get renewals and reauthorizations coming through. So you'll see this in a few slides as well, but again, throughout this whole process, we do want to kind of reinforce, try not to get discouraged by denials, objections that come through. There is a lot of data, there's a lot of information, there's kind of a lot of precedent now, especially for those initial approvals, to push back and really kind of push the case for getting approvals to come through. One of the things that we'll see on the next two slides that we're going to get into is there's national policies and there's state policies that are out there. Those policies aren't fixed though. They're a policy that you can push back, and if there's a gap in coverage, it's not fixed in stone, and we have seen that approvals come through even when there's a category here on a policy that says no. So the first slide summarizes, and these are some of the slides now that we won't spend too much time on. 6 are the big commercial providers, and where they kind of have broken down their policies by type, by copy number, adult, pediatric. I think one of the takeaways from this slide is, where we see the gaps, and some, not all, of the commercial providers saying that they're not providing coverages for the extremes, so type 0 and type 4s. And then a bit, not quite to the same extent, but for adults as well. That's where we're seeing some of the gaps in coverage. So that's what we're focused on as well. So the extremes of types, and then adult patients with the commercial providers. In the Medicaid area, so this is each individual state, we've got about 16 that have come out now. And you'll see some of the same patterns, again, on kind of the extremes. There's some of the gaps for type 0s and type 4s. It's actually interesting that there's not as many gaps for adults with the Medicaid states, the 16 that we've got so far, but there is something which is a little bit different with the trach. So the actual commercial providers seem to cover more on the trach side, whereas some of the Medicaid states have more of the gaps there. So that's kind of just a summary of these areas. And again, we're seeing some good coverage for kind of some of the middle categories, but what we're really focused on is we've got to expand the coverage with both some of the commercial and some of the states for the extremes that we're talking about. So type 0s, type 4s, adult, and trach are kind of the key areas that we're spending a lot of time focusing, doing advocacy, providing data where we've got it already, and knowing where we've got to maybe collect more data as well for the future to support getting coverage. So the next slide is a summary of something that you can hear, I think, throughout some of these next stages. It's a slide which kind of, I think, shows when we're talking about getting initial insurance coverage. This is also relevant, though, when some patients are going in actually talking to doctors and clinicians, and it's also going to be relevant when we're talking about renewals, reauthorizations. And it's really talking about what are some of the expectations, what are some of the ways that people should expect the drug to work. This is also about what we've collected information and data on about what is important to patients and families. What is it that's actually valuable from a therapy that should be getting covered? And so what we're trying to show here is you've kind of got a natural history of SMA, and this is that downward progression over time, that green line. The 3 other lines there, what we're trying to say is all of those 3 situations should be termed improvements. That's what all of you, patients, families, we've heard over time, consider valuable. Any of those situations are what insurance coverage providers should be saying is valuable as well, and providing coverage for if that's the situation that turns up. And also if that's what plays out over time, a renewal should be given. So whether it's just a slowing down of the progression, it might still be going downhill, but just at a slower rate, or stopping progression where it is, or actually improvements, increases over time. All of those are improvements. All of those are valuable. All of those, if they come from Spinraza, suggest that, you know, there should be insurance coverage. It shouldn't just be that one case of an increase. We want to make sure that we're getting initial approvals, we're getting doctors to prescribe, and we're also getting the reauthorizations for all of those top three. Increases, maintaining, or even just kind of slowing down progression. There is information, there's data, there's reports that are out there that we've been giving, you can get access to as well, again, with doctors and insurance providers to show that this is what we're looking for. And again, this also, though, comes down to your own experience, what it is that you want to advocate for, what's important to you, what's meaningful, why it is that you should be getting access to this therapy. So the next slide, we tried to summarize a little bit, again, on expectations. This more, not from this kind of high-level overview of improvements, but from clinical trials. And actually, I'll just hop back a little bit, sorry if I went forward here. I just wanted to talk about the timeline as well. So not just the changes, increases, maintain, or slowing progression. One of the other key things, and this is now relevant for kind of the renewals part, is about giving the drug time to work as well. That the expectation here isn't that, you know, everybody's going to see changes, whatever it is, very quickly, we're talking about weeks or months, that the therapy here needs time to work, that we're really talking years rather than weeks or months for the drug to be able to show an impact. That's what the expectation should be with doctors and insurance providers, giving it time to work before some of those decisions on renewals come through. Sorry, so I just turn over to the next slide, and Jill's going to take this one. More from what we currently have from the clinical trials data, but also what's maybe pending to come out, what some of the expectations of the therapy can be.
So I think most of you have probably seen this data already, but in the ENDEAR data, which is in the infant population, 51% of the infants gained motor milestones versus 0% in the untreated group. And then, you know, an example of a motor milestone would be able to move your hands or gain head control. And then also 61% of infants were alive and did not require permanent ventilation versus 32% in the control cohort. We're expecting data to come out that is going to be important, I think, for advocating for insurance coverage. Some of that data will be at the World Muscle Society in October. We haven't that data we don't have access to yet, which includes permanent data on patients that are on permanent ventilation, data from the EMBRACE trial, which was in older type 1 patients, beyond those that were in the ENDEAR trial, and then also from the early access program. In the CHERISH trial, which was in children from 2 to 12 years of age, they gained 4 points on the Hammersmith over the duration of the trial versus the loss of 1 point in the untreated group. And just so people realize what the Hammersmith scale is it's a 33-point scale where you get a 0 if you can't do the item, a 1 if you can partially complete the item, and a 2 if you complete the item fully. And these items range anywhere from things that have to do with rolling over, putting your hands onto your shoulders, walking up steps, walking upstairs. So it's a whole range of functional outcomes. So gaining 4 points on that scale is gaining 2 items of the 33. So as Kenneth mentioned, we still don't have data in older teens and adults to report, and that data needs to be collected. And another thing to keep in mind is that the clinical trial data has shown that it takes time to see these results. Most of these results took between 6 and 12 months to materialize, and they're not seen in the first couple weeks of drug treatment according to the clinical trial data. And in fact, in the ENDEAR data, at the interim analysis, 41% of infants had gained motor milestones, where at the end of the study, now 51% had gained motor milestones. So these patients are continuing to gain motor milestones with time. Next slide.
So this next slide is talking about a stage that we're just really kind of starting to see and moving into now, which isn't patients starting on therapy and getting the initial kind of approvals, that process, but a lot of what's in place is insurance providers are going to look sometimes 6 months, a year in to renew and give reauthorization. So we're just starting to see this come up now. We're starting to hear from some patients that are going through this process. One of the key items that we want to kind of make as a recommendation is right off the bat to know up front is if you can actually keep your own records, whether it's notes, especially videos, those are going to be helpful for this process when you reach it as well, when you get to the renewals. Any information, any data to show any of those improvements is going to be helpful. And again, the improvements, increases, maintaining, or just kind of what you're not going to be able to show so much, but it'll be able to show as a comparison, just slowing progression compared to what would be expected. So definitely keep your own records and notes as much as possible right from the beginning of actually getting on therapy. That's going to help when renewals come up. Summarizing again, kind of I think what we talked about for this part, we want to make sure that the drug is given enough time to work. And again, not so much about weeks or months, but measuring this in a year or two. That's really the time that you've got to give for ultimately muscle to build up, for some of those changes to really be visible against what would have happened with the natural course of the disease, the natural history. You've got to have kind of a big enough spread so it's not just kind of random noise that an insurance company might say they're seeing. The other side as well is when you see some of these lines, those are averages, and I think we've maybe said that in some of the other presentations. When you see some of these kind of results from clinical trials, they're averages over all the patients. Some did better, some did worse. You've got to give it enough time really for, not everybody's going to be at the line or above. For some patients that might move more slowly, we've got to give that time to kind of have a separation against the natural history. And again, just summarizing again, what we say is kind of valuable, what we've got as evidence from all of you in the community is any of these changes, these improvements are valuable, should be covered, and should continue to be covered over time as well. At the bottom here, we just wanted to highlight there's going to be some more opportunity as well, not just for your own kind of advocacy, your own individual advocacy case by case, but helping kind of the overall community, providing the kind of community angle to this as well, where a risk-benefit survey is going to be going on, and also we're going to have our second annual membership update over the next few months coming out. That's information which reinforces these arguments of what's valuable, what improvements are valuable to you as a community that we can then share with these providers to reinforce initial approvals, but this key reauthorization that's going to come up. And we've actually heard from that. We'll come into these next slides. The insurance providers, particularly Medicare, Medicaid, wants to see that information. They do want to know what you see as valuable to help them in making their decisions, in some ways the same way that the FDA did when we went for the original approval. So the next slide is going to summarize, and we'll get down to some more detail about what we've been doing to kind of to focus on improving the coverage that's out there from these insurance providers.
So I'm going to quickly summarize this. Many of these initiatives are ones that we've covered in previous Access webinars. So I'll just give a very quick summary. As most of you know by now, back when Spinraza was approved, we sent out letters to CEOs and CMOs of major insurance plans, as well as the state Medicaid directors and governors of all the 50 states. And this was part educational to explain to them, for those who weren't aware, what SMA is, what is important to our community, what are some of the effects of the disease, and then the importance of Spinraza, what promise it shows for our community, and why we believe it should be covered, and not just covered for certain types or certain ages, but covered broadly. What we've seen from this is, number one, just the initial opportunity to educate them, but we've also seen this help us build relationships. And so when things have happened, when new data has come out, or when new issues have come forward, we've been able to continue that dialogue with both the state and commercial providers. We've also had a couple of meetings with national organizations, government agencies. I will talk about that more in just a little bit. And then I wanted to make you aware of a couple of resources that we've released on our website. And so you can find these on our news section, or if you go to the Support and Care section of our website and go to Support and Care Publications, you'll see a new Care Series booklet we put out earlier this year. This one doesn't talk so much about Spinraza specifically, but talks more about some of the broader decisions that we know many in our community have to make. And then the congressional caseworkers piece is specifically applicable to Spinraza, but could be applicable to other areas as well. And that's about how you can use your local congressional office to help advocate for Medicaid coverage. Specifically related to Medicare, back in August, we had the opportunity to go and meet with some folks from Medicare. Medicare works a little bit differently from Medicaid. So Medicaid is sort of a top-down process. The state comes in, issues a policy, and then that filters down to the individual cases and guides them. Medicare works in the reverse way. So what they do is they look at each individual approval or denial on a case-by-case basis, looking for a consensus to emerge, and then that's often followed by the issuance of a national policy. And so one of the things that they ask for our help for is to find out, do they need to perhaps speed up this process of issuing a national policy? Is this a process that can continue to work itself out on a case-by-case basis? Really just what has been the experience of our community and how can they help? So at the bottom of the slide, you will see a link, events.curesma.org/Medicare, or again, if you go to our news section and just search for Medicare. For those of you who have Medicare as either your primary or secondary insurance, or if you're a caregiver to someone who has Medicare, we just want to know what has been your experience. Have you filed for an approval? Were you approved? Were you denied? Is it pending? What information has come back to you through that process? We're going to collect all of that data and then report it to the National Medicare folks. So one thing to note, we do ask for your name and your email address when you complete this, just so if we have questions or we need to follow up, we can reach out to you. But we're not going to be sharing any personal information with Medicare. This will be only de-identified aggregate data.
The next slide is really more of a summary, I think, of our approach, how we've been going in with kind of an overall message of advocacy. What we're saying we would recommend for a lot of people to be kind of coming in with this type of messaging when you're in these discussions with different groups. And this is the approach that we're saying. It's the same approach and a lot of the same information that was used with the FDA to get the initial approval, the early broad approval. We now need to use that same information and approach with these other groups that are now involved in the process, with its doctors trying to get the prescriptions going. We actually do hear that some doctors aren't aware, or they might not kind of believe that the impact from the drug is valuable to a patient. Particularly in some of the older groups, we hear that. That's an objection, and it's something which there's data, it's your own advocacy to push back on and say, no, this is valuable, and trying to get that doctor to kind of move initially with some of the prescription steps. It's also with hospitals, trying to get hospitals up and running with their processes and their structure to have the resources and have kind of that process up and running to dose patients. Some of that takes some advocacy work as well. And then finally, there's a lot of what we've gone over with the insurance groups as well, advocating with them on what's the benefit from this therapy, why it's valuable, and why it should be covered. We're taking the same approach as we did with the FDA of this being positive. It's about data, it's about information and the stories that come from the SMA community in a very positive way. But that comes with not taking no for an answer. It's about staying motivated. It can be frustrating. We know in this first year that we're in, it's going through a lot of processes where you're going to hear no, things might move slowly, people might push back. But, it really is something about staying motivated, not taking no for an answer, where we've seen once you go through those steps, it does seem to work more often than not. And we do see a lot of people, while they might get initial denials, sometimes two, eventually it comes through. We've seen some of the state Medicaid programs expanding coverage when we've provided more information and data, and a few of the commercial ones again. So what this also is, I think we look at this first year about setting a precedent. There's a lot of first-time interactions here with groups that were never involved in SMA in the past. And we've got to go through this awareness and education and then advocacy, really kind of pushing the need of data to get all these groups up and running. And then we hope, as we've been through once or twice with these first-time kind of groups coming into the SMA field, the process should move smoother in the future. What we're also kind of summarizing as well kind of is the overall message as well about the data that we've got, but also why, even though you might not have some data yet in certain types and ages, there's an argument for why in SMA, really this therapy should work for everybody. The angle that the FDA took where they gave the broad label, all ages, all types, pediatric and adult, and no restrictions. And so this is, hopefully a good talking point that we've been pushing, and you can as well when you get objections. But it's about SMA being really just one disease. It's not about the different types. And there's a really good rationale for that it's the same genetic disease. Everybody, pediatric, adult, all the different types have the same genetic cause. And then I think critically with Spinraza, everybody has the same target that the drug works on. So if it's going to work for a certain type with the same SMN2, it's going to work for a different type as well. And so, again, while there might not be some data for certain groups, the argument of how the drug works and why it should work is a very strong one in SMA. And I think as well, there is multiple clinical trial data. The trials were done in certain kind of groups of criteria to do them in the best way possible, but it was done across broad categories as well. So you should be able to kind of see, and this is the argument we make to insurers, that it isn't just a one-off, certain age, certain type. It's been studied in multiple ages, multiple types, and shown significant benefit. I think as well, the final point is what we were talking about earlier about what's meaningful here. I don't think anybody's really looking and saying, this is the cure and that's why it should be paid for. It's a very effective treatment. It can be very powerful. What we're really looking for and what's valuable at this stage and what we really kind of want insurers to cover is if this just does some kind of improvement of maintaining current status, slowing progression, that's a huge step forward for us as a community. That's very valuable and that should get the coverage, and that's what we're pushing for. So the next slide summarized here, and we're going to get into a little bit of a different topic, which is the other aspects of what's going on in the community, not just the first approval that we got, but other clinical trials, other decisions that we've heard people are trying to evaluate. And so we wanted to talk a little bit about current clinical trials and some in the future as well. So Jill, do you want to start off on this slide?
Yeah, sure. So we get a lot of questions about current clinical trials and how to think about them versus the approved drug. And right now there are 4 clinical trials enrolling in the U.S. The first one is from Cytokinetics, and it's called CK2127107. And it's a phase 2 trial for teens and adults looking at a drug that enhances muscle therapy. There are 2 studies by Roche looking at their small molecule, which is an oral tablet that you would increases SMN2 levels. The first is called Firefish, and it's in infants 1 to 7 months with type 1 SMA. And then the second one is called Sunfish by Roche, and it is in teens, children and adults aged 2 to 25 with type 2 or 3 SMA. And then the third one is also from Roche and their small molecule SMN2 enhancer called Jewelfish. And this is for children, teens, and adults age, it says 12 to 60, but I think we should check. So 12 to 60, and who have been exposed previously to other SMN2 enhancing drugs. So if you discontinued, say, Spinraza, you could go into this trial if you were interested. And we also get a lot of questions on considerations of how to think about the approved treatment versus trials. And this is really a personal decision, and it's dependent on many factors, and no one can tell you what the right or wrong answer is. It's really important that you go to your physician, your neurologist, and you talk about these, and you ask your neurologist to talk you through what the available safety and efficacy data is on the current therapy, approved therapy, and on the drugs and trials, that you understand how the drug is being given. First, is it an oral drug, IV injection, intrathecally administered drug, and how often you have to receive the drug. It's also really important to understand the inclusion and exclusion criteria because, if it's from 0 to 180 days and your child is 183 days, you could be very disappointed. It's also important to understand the exclusion criteria. Sometimes there are exclusions for things like spinal rods or spinal fusions, but also it's very typical that most trials today will prohibit co-utilization with Spinraza. So you really want to look into that. It's also, most drugs will inhibit co-utilization or concurrent exposure with any other drug that could increase SMN levels. So you really want to look at what they list and what the washout period is for those drugs. So these are all things that's really important to talk to your physician about. We actually recommend that you don't wait to go on any treatment to wait for a trial to open, a trial that's not ongoing today. And the reason for that is that delays in opening trials are very common. This does not mean there's a problem with the drug program, but it's oftentimes just logistics and administration that will cause them to delay 3-4 months, and then your child could time out, or you could time out from the inclusion in that trial. Also, exclusion and inclusion criteria are often changed at the last minute, and so you may hear that the age range is 2 to 50, and in the end it may end up it's 5 to 30, and you'll be left out. And also, one of the biggest things to think about in with SMN drugs is timing. We know from animal models and from the nurture versus the endear data with Spinraza, the earliest administration will give best results, and this is particularly true for newly diagnosed patients. So one of the most important things is getting SMN increased as early as possible, and waiting 6 months to a year could have a big difference in the impact. So I think these are all things to go back and think about and talk to your doctor when you're considering entering a trial versus taking approved therapy. Next slide.
And I'll maybe just add a few other points on that, probably just reiterating some of the things that Jill said. But I think we know this is a difficult area overall. There's some difficult decisions here. But I think what we're trying to break it down to is looking at the areas where you know things, you have information to make choices on, and that would be about current care choices, current clinical trials that are up and running, or currently approved treatments. No easy decisions, but those are the areas where there's current information and you can weigh them up and make the personal choices. I think what we're trying to kind of say overall in the message here, though, is this other area about potentially future clinical trials. That's a big unknown. And in some ways, we are recommending not to make decisions today based on what could be out there in the future, just because there's so much that you don't know about, and things, as Jill's saying, can change. Future trials, things might change. You don't know the numbers that are going to be in those trials, what the criteria ultimately might be, where they might be located. So it really is best to try to make the decisions today on what the current opportunities are, rather than current decisions about some potential future trial. We know that's difficult, though, because, again, one of the key items here, just so everybody does know it, is once you've got access to an approved therapy or a current clinical trial, that may exclude you from something in the future. But again, our recommendation is focus on what's available now, today. There's just too many unknowns about future trials to try and delay things and wait for those things to open up.
So we're going to very quickly touch on international approvals. All the information that we've given you thus far is generally specific to the United States. Some of the information on clinical trial data, of course, has applicability to other areas, but in terms of the regulatory and dosing, that all applies specifically to the U.S. But there are several other areas where Spinraza is now approved or where it is currently pending. And so the European Union, Japan, Canada, and Brazil, Spinraza is approved in all of those areas, again, in addition to the United States. There are pending applications in Switzerland, Israel, South Korea, and Australia, and then additional filings are also being planned. Again, our website is the best place to stay updated as new international approvals come forward, whether it's the approval or whether it's news of an application being filed. We do post those on our news section, curesma.org/news.
So this last slide, a little bit different again, but it's some information that we've started to collect, and we did want to kind of say, please let us know as well if you have any items that you might want to provide to us that we could share with the community here about some tips for some of these initial visits and appointments as you're maybe kind of getting the process going for getting approvals. Some of these are kind of simple, small items, but what we've seen is, some of these, if they get missed, they can cause delays. They can cause you to kind of have repeat visits and going back and forth. So small items, but they can actually, if you can try to get some of them done up front and in one go, they can save time overall. So some of this is just small items, filling information out on start forms before you go in for visits. making sure with some of these first appointments, you're bringing as much information with you as possible, your insurance cards, and items like that. Some of them, I think, are just small items that hopefully you don't have to do, but making sure small details, things are signed off, that prescriptions are included with some of the start forms. Those can actually be important. They can kind of prevent some of these delays that we've heard about. One of the key things is this genetic testing part. It's an item that we've seen that if you've got your genetic test results for SMA, sometimes the copy number, that can be important to take in with you. It can prevent a delay of coming back in later. If for some people we've seen some of those test results are not available at a new institution that you go into, they may have been from a long time past, it might be something that you want to get done on your first visit in. A lot of insurance companies are going to say that's a criteria where you have to show the genetic results showing that this is SMN1, deletion mutation, but then also you've got to sometimes have the right copy number to match up with their policies and be able to show that with a genetic test as well. And then we know there's some complications, but you can try to get around some of the delays. If you've got rods or fusion, looking to try and see if with the rods, can you get an X-ray or a CT scan done? And that'll actually help some of those decisions of whether there's actually going to be space there for the lumbar injection to go in. Again, though, just some initial ideas here, and I think this is one of those areas where we can collect some experiences, try to reduce some of these smaller delays or smaller items that are causing delays.
All right, fantastic. Thank you, Kenneth, and thank you, Jill. We've got a couple questions, and so we'll get through as many of those as we can right now before the top of the hour. So I actually want to start with a question that relates to something, Kenneth, you just spoke about, which is spinal fusion. And so we've received several questions about this, including those who have heard that a protocol or a device for administering this through spinal fusion might need separate FDA approval. So can you talk about what you know about that protocol and where that's at?
So the place to start really is that from the clinical trials that were done, all of those had the lumbar injection. That's the procedure that was done for all of the clinical trials. That's all the information that went to the FDA. So the FDA label is kind of based on that part. What we started to see, though, is with some of the approval, some of the actual dosing going on now, there's a number of approaches that are being taken. Some of this really, I think, is in kind of the stage of trying out different processes, procedures, where rods, but more it's the fusion part, is coming into factor into this. So there's certainly some steps that are being done where it's still the lumbar injection, but it's trying to go in where the fusion's there, but where there might still be gaps and openings to allow that injection to take place. That's been happening. We've seen some of the first steps to see is there's a device, if there's a port that can be put in the lumbar area as well. There would be a surgery that gets the port in there, and then it's kind of set up in the lumbar area for injections in the future. A new area that we started to see come up is some injections, but also looking for ports to be put in the cervical area as well. If the lumbar area is actually kind of ruled out because of the fusion, can it be put in higher up? So I think all of this now is in kind of a real-world testing situation. None of that was done in clinical trials. It can happen. I think that's kind of individual physician prescription decisions on which approach to take. But it isn't part of the FDA approval, so that's where some of this will come into. Is an insurance provider going to cover the administration of its injection? But I think more when it's a surgery for putting a port in. Ultimately, I think things will happen now a little bit case by case. Once it gets worked out what the best approach is to get a lot of people to kind of have that procedure done, you're ultimately, if it's going to have a device, going to need the FDA approval to really enforce the insurance coverage to allow that to happen. I think just anecdotes one thing that we can kind of say is it seems like there's not a lot of these being done, but the lumbar ports are starting to happen. We've seen a few of the cervical ports. We've heard of a few issues with the cervical injection, and that seems to be something to be very careful about, to make sure that that's a really in-depth discussion between you, your physician, surgeon, to really kind of focus on that, something very different than what was done in the trials. Jill, is there anything you want to add on that?
No, I think you covered everything.
So another question that says, I'm pregnant with a baby with SMA and would like to have them dose Spinraza as soon as they're born. So can you talk about pre-symptomatic dosing? First of all, what kind of results can be expected? And then second of all, if we're seeing insurance companies cover that as well, or if we're hearing about pushback. So perhaps, Jill, I'll go to you first to talk about the data and results in pre-symptomatic dosing.
So I think it depends that there is data from the Biogen Nurture study in babies with 2 and 3 copies of SMN2. And those babies have done very well compared to the babies in the ENDEAR trial or the symptomatic trial, who's also done well, but the gains were more dramatic. So we reviewed that in the ENDEAR trial, the symptomatic infants, 51% of them gained motor milestones, and 62% of them were ventilation-free and alive. For the Nurture trial, the babies that are analogous, which are the babies with 2 copies of SMN2, all of them are ventilator-free and breathing on their own and alive, and all of them are gaining milestones. In fact, many of them are trending and attaining milestones at a similar level to unaffected children, but not all of them, and also a number of the infants were still quite young at the last data cut. This does not mean that this pre-symptomatic treatment is a cure and that these children will not have SMA, but the gains are quite dramatic with pre-symptomatic treatment, which is aside one of the reasons why we are advocating for newborn screening for SMA. In terms of insurance coverage or Medicaid coverage, very few insurance policies or Medicaid policies have a stated determination on pre-symptomatic treatment, although I think we've heard of a number of cases where patients who were born did receive pre-symptomatic treatment.
And it really seems on the insurance side that there's going to be some strong data to support the coverage, data from trials which just show kind of younger, and also some of the data that's maybe come out but will come out over time from kind of the Nurture study. It's more going to be a situation of how quickly that can move with just going through the insurance process, because obviously it's pre-symptomatic, so time is the essence. You don't want to have to go through kind of many rounds of discussions getting the approval to come through.
So our next question is about kind of something you mentioned, the importance of advocating not only with insurance companies, but sometimes with your healthcare provider as well. So the question is, what resources can I point my doctor toward to demonstrate the benefits of Spinraza in adult recipients, keeping in mind that there is as yet no clinical trial data on that population?
So I think some of this is it's definitely kind of the individual advocacy for somebody just to kind of push what they see as their own benefit, what functions you're really kind of saying are very important to maintain, small increases that could be important. I think the information that's available to support that is not so much then from the clinical trials, but from some of the reports, the publications that we've been able to pull together. So I think if you're able to kind of make an argument on an individual level, but then back it up with some of the reports and information that we have, such as the Voices Project, and there's some studies and focus groups that we did. You can back up, here's an individual point of view, my own, but then this is widespread. This is a viewpoint that's represented across the whole SMA community when talking about maintaining function is very important. Small incremental changes can have a very big impact. So individual plus the information that we have on our website as well from some of these publications and reports on meaningful change, meaningful benefit.
Just a quick note before we get to the next question. I'm seeing a couple questions regarding Medicaid specifically, and most of the questions are, my state was not listed on the chart that was shown earlier. How can I find out information about when my state does issue a policy? And I want to note it's caresma.org/Spinraza. As we become aware of these policies and as they're made public, we do post them there. And so that's a place that you can track for future Medicaid policies as they become available. And Kenneth, I don't know if you have anything to add on that.
And the only item to add is there's certainly, we've got 16 states here that have their formal policies there. There's a lot of other states which are not on this list. They haven't put a policy out, but they are approving case by case. That there are Medicaid programs not listed here where they are giving approvals, where they are giving coverage. So it's not like it's a holding pattern for those other areas. It's just they haven't come out and published their actual policy yet.
And then the other question that I'm seeing pop up a couple of times is whether the presentation and slides will be available. The answer is yes. We'll be posting both a recording of this presentation and a PDF of these slides on our website just within the next couple of days. So if you missed any part of this presentation or just want to review the information, you'll be able to do that. We have time for a couple more questions. I want to ask specifically about the Cherish data. So we have a question here that some of the earlier policies that we saw come out were very restrictive, only type 1. At that point, the Cherish data had not come out. It has come out since then. Have we seen any specific movement or loosening of policies in light of the Cherish data? Perhaps, Jill, I'll put it to you first to talk about the impact of that data, and then Kenneth, anything specific to add to that.
I think the Cherish data, which was in children with type 2 SMA between 2 and 12 years old, showed a clear demonstration of gaining motor function, where they increased 2 points on the Hammersmith scale opposed to the children who were in the control cohort who lost the point. And that is 2 functional items typically on the Hammersmith scale out of 33. I do think it helped. I think Kenneth probably has some specific examples of where that occurred.
So we did see some changes, and it's kind of an overall ongoing message, but it seemed to be triggered a little bit by this new data coming out. Some of the changes with the Anthem commercial policy. We're waiting for some of the final confirmations, but it seems like it's been effective, again, with bigger arguments as well, but that specific data. On some of the Medicaid ones with Oregon, North Carolina, I think it's still pending, and Michigan, we're waiting to see if they're going to kind of change the initial policy that they came out with. So it seems like it is. More data comes out, especially when it's published, can have an impact and kind of start to fill in some of those gaps with no's on the extremes. And so, again, when we get data, it's something that we push. We've got these kind of results, these publications available on the website for you as well to get these and give them to your providers, give them to insurers on initial requests, but also if you get denials. And then when the data comes out that Jill was talking about, the data that's out there that's yet to be published, we'll make sure that that gets available. We'll push it out to these groups, but also get it available to you so you can give it to your directly to the groups that you're working with as well.
So another great question just came through on the topic of advocacy, and so this is, if we know of a site in our local area that either is perhaps considering administering Spinraza or might be administering it but isn't yet on the public list, how can we advocate for those sites to either become Spinraza administration sites or to share that information publicly so that the whole community can benefit?
So it's definitely sending us the information as well, and I think, Megan, is it patientcare@cureSMA.org?
Yes, patientcare@cureSMA.org.
Basically sending any information on the site, who specific contact might be at that site. That allows us to reach out to those areas and provide them with all of the materials that we have available. And while you're doing that, if you've heard a specific question from a site that they're looking for more information, we can give that to you to pass on as well. But really, getting the information here allows us to then be in direct contact, give awareness, give education, and then ultimately try to get them onto the public list so that they're available for anybody to contact. And so again, it's patientcare@curesma.org.
Yes, patientcare@curesma.org. If for some reason you don't have a pen nearby, can't write that down, you can always just use the standard info@curesma.org, and we'll be sure to forward that on through. Several of you are also asking about the resources that Kenneth mentioned a little bit earlier, the Voices Project, some of the focus group items as well. How you can get access to that. We'll go ahead and we'll send out that information in the follow-up email. So in a couple days from now, you'll get an email about this webinar, asking some questions. Was it helpful? What topics do you want us to cover in the future? And we will go ahead and send on those resources as well.
And then the item to add as well, that's what we have available now that we've collected from the community, but please watch out as well for this risk-benefit survey and also the annual membership update that should be coming in maybe 3 or 4 months. That's kind of more information, again, that we collect. We compile that together, and then we'll make it available for all of you, but we'll also make sure that it gets out to all of these commercial providers, the state Medicaid, and Medicare as well, who's been asking to see it.
So a couple folks are asking about possible different methods of injection other than in the spinal cord. Is there any thought to exploring whether Spinraza can be delivered via an IV or another method?
Gail, do you want to take that?
I think there are certain centers are using other delivery methods, but I think it's important to keep in mind that there's no data on the efficacy or safety of these other methods. We don't know if they work as well or if they're safe or if they have any sort of long-term complications with that type of delivery. So that's just one thing to keep in mind.
So I think, Jill, just to clarify, the question was specifically about systemic delivery of Spinraza and if that is possible.
Oh, I thought you were talking about ports or something like that. Well, I think there is no current data about systemic delivery of Spinraza. I don't know of any plans of moving in that direction. That being said, it doesn't mean that it's not going to occur at some point, but certainly we haven't heard of any clinical trials or tests, and I think that delivering Spinraza systemically would have a whole different, would require another set of clinical trials.
So I think we've got time for just one last question. We just have a minute left. So this question is about insurance companies that are taking a longer time to review claims. And so is there any way to advocate with an insurance company to, to issue a decision, whether it's an approval or a denial? This is specifically in the context of the fact that to get Biogen's support program, you need to have had 2 denials. And so we're seeing some folks say that there's just been a long period of time when they want a decision so that they can move forward with potential other options.
So I'll try something first, but then Jill, I think here it's kind of the general argument approach about how important time is here, that this is really about the sooner that you can get the therapy delivered, the better impact that you're going to have. And that isn't meaning younger, it's just the sooner. It doesn't matter whether it's somebody that is an infant or somebody that's an adult, it doesn't matter what the type is, but in all the cases, really, we're trying to get the therapy in before motor neurons are lost. And that's kind of the thing about why things are so urgent, that when you get the therapy in before motor neurons are gone, it has a better chance of actually kind of keeping those motor neurons there. It has the chance, if there's some that are kind of in an interim stage, of getting those to reconnect, re-innovate, and maybe kind of this sprouting that people have talked about. So that's why I think why it's so urgent, that it's very difficult to bring things back after you've lost them. And so another argument I think we've put out there as well is about, you don't want to lose any more function. It's kind of that stage of, if you lose a particular ability or function, it's much more difficult to bring it back than to get the therapy in and maintain it. And so that's why it's so critical to move things very quickly rather than waiting weeks or months. That could mean one critical step down on that natural history, and it's so much more difficult to come back rather than just maintain. Jill, is there anything to add on why so urgent on initial approvals?
Well, I think that, this idea of early is better, as Kenneth said, is probably true in all cases, but it's more urgent in infants with 2 or 3 copies of SMN2, or younger patients. We believe that more earlier is better, because, as Kenneth said, if you lose motor neurons, you can't get them back. You may be able to get the ones that are still there to function better or sprout, and you also can't reverse certain secondary complications and things of that nature. So earlier is better across the board, particularly urgent in infants with 2 copies of SMN2.
All right, we are past our end time. I want to thank all of you for joining us.
So we'll be doing another, probably towards the end of October, November time, we'll do another webinar update
Correct.
again.
Yes, correct.
Situation then.
Yes, correct. So again, you will receive a survey link, and then it will ask you about topics that you would like to see covered in future webinars. And so definitely complete that. That'll help us plan the next one. Again, info@curesma.org. If you need to reach out to us, if you have additional questions, please send them that way. Again, site data, patient care@curesma.org. All right, everyone, thank you so much.
Thank you.